by definition, postpartum depression means you meet criteria for major depressive disorder, but it's within a specified time frame. There's a little bit of debate about the time frame, but essentially greater than 2 weeks after you deliver and less than 1 year. Now, again, there's some people that say postpartum depression lasts longer, and there's some people that say that postpartum blues can lead to postpartum depression, but for the most part, greater than 2 weeks, less than 1 year, and you have to meet major depression criteria. Basically, if you just look for diagnostic criteria for major depression and find that time frame, you're within it. Prevalence is about 10%. It's different for different countries. Apparently, Holland and Sweden are much happier than us because their rates are much lower than ours. There's other people that are worse, but ours is about 10% depending on the study. Risk factor is the most consistent is a history of depression. So if you've been depressed throughout your life, or more importantly, if you've been depressed throughout the pregnancy, if you halfway through the pregnancy you go to your doctor and you say, gosh, I think I need to be on an antidepressant, I'm having a hard time, these are the people that are at most risk for getting postpartum depression. So peripartum depression is the greatest risk factor for postpartum depression. It's okay, Heather, you can go ahead and text while I'm talking. It's not that big of a deal. All other things that are risk factors are things that we would consider stressors, the big stressors. Anything that quote unquote makes your life harder is going to put you at risk for postpartum depression. So I'm a single mom, I'm a young mom, I'm a first mom, I've got 7 other children at home, my husband is abusive, I live in a poor socioeconomic state, I'm not very well educated and poorly educated. I live in government housing. Anything that puts you in a stressful situation is going to put you at risk for postpartum depression. The pathogenesis of it, for the most part, there's about 3 guiding theories. One is it's genetic and it's completely out of our hands, and your mom had it, your grandma had it, and you're going to get it. There's actually some people that believe that there's a gene that is passed that can cause these things. The other big category is hormone changes. You get a significant drop in estrogen and progesterone. After you deliver, your prolactin goes up, which further drives your estrogen down, and those hormone changes can have negative effects on your mood as well. The clinical manifestations, most of the time what we're going to see is these criteria that we showed you a minute ago, but basically depressed mood most of the day, nearly every day, for greater than a 2-week period. Markedly diminished interest and pleasure, significant weight loss, psychomotor agitation, fatigue, feelings of worthlessness, diminished ability to think or concentrate, those type of things. And again, there's a chart you can look at, but all the major depressive symptoms are what you're gonna see. The general course is about 1 year, with or without treatment. Obviously, with treatment, the patient will feel better and usually will get better faster. But most of the time it will run its course in about a year's time. About 30 to 40% of people will have recurrence at some point in their life. We no longer call it postpartum depression after it's a year, but then they usually fall into a category of either minor or major depressive disorder, depending on the criteria. There are a lot of adverse consequences other than just the mom being sad. We used to say, well, gosh, let's give her Prozac so she feels better. But the truth of the matter is there's a lot of downstream things that can happen. The breastfeeding rates are dramatically decreased in women with postpartum depression. There's decreased bonding with the infant. Child health care, the trips to the pediatrician dramatically decrease in a woman who's got postpartum depression. And then the major things that we really, really concern ourselves with, the suicide rate, about 1 in 100,000, which seems low, but when you compare it to how many babies that are being born every year, it's really not a low number. And then infanticide or feticide, which is destruction of the infant in utero or postpartum. And that is about the same for postpartum depression. It's about 1 in 100,000 or so. So assessment, what kind of things are you going to see? They're going to come to your office or to our office complaining about concern for their infant, that they're not being a good mother, they're not taking care of the child the way they're supposed to. They'll have a negative perception of the infant sometimes. They'll say, oh, this baby never stops crying, oh, something's wrong with the baby it's not doing what it's supposed to do, what they perceive as a normal baby. So they have almost a negative perception of the infant and a negative perception on their ability to care for the infant. Sometimes they'll have a lack of interest in the infant. And then non-adherence to their care as well. Just like they have a lack of trips to the pediatrician, a lot of times they won't show up for their postpartum visit, they won't come back for birth control care, those kind of things. And increase in drug and alcohol use. And then finally, the opposite of non-adherence to care is frequent care. This is how when we see, someone comes in because their incision looks infected with them. Then 3 days later, someone comes in because they're having trouble breastfeeding. Then 3 days later, someone comes in because they're constipated. Then 3 days later, they come in because their heartburn just won't get any better. That's a cry for help. Someone who's seeing 5, 6, 7 times postpartum, there's something else going on there. They shouldn't have that many normal issues related. The screening test, which is that most of us use in the offices, the pediatricians use it, and I think you guys are going to start using it now on postpartum, is the Edinburgh scale. And then finally, our differential diagnosis is the postpartum blues. And postpartum blues is kind of a step above normal fatigue. If you ask any mom who's got a baby at home, they're a little bit sleep deprived, they can't remember the last time they brushed their teeth or had a shower, they don't really take great care of themselves, and a little bit of that is normal. Postpartum blues, what differentiates that from postpartum depression? It usually always occurs in the first 2 weeks. So these are the girls that have a baby on Friday, they get discharged on Sunday, they call us Tuesday and say they're completely overwhelmed, they can't get everything straight, they're not sure that they're doing it right, they're not, the breastfeeding thing's not going their way. We bring them in, we talk to them, we give them some encouragement, we get them to speak with the breastfeeding coordinator, and then we see them back at 2-week visit, they're doing good. They pulled their boots up, or pulled their, what's that expression? Pull themselves up by the bootstraps, and they're doing great again. That's postpartum blues. And I think a whole lot of people fall in that category of normal to a little bit more postpartum blues, but for the most part that goes away within a week or so, week to 10 days. When it starts lingering, then we start asking them the Edinburgh questions. That's when we start saying, hey, have you lost interest in doing things? Are you spending a lot of time alone? Are you sleeping more than you like to? Are you not eating enough? And then the other thing that's in the differential is bipolar disorder. So the big differentiating factor there is, are they having episodes of mania as well? This is the woman that comes in, she acts like she's depressed, she acts like she's got major depressive disorder, she's really fatigued and all this stuff, and then her mother will pull you aside and say, I can't get her to stop cleaning. She goes through these spurts for like 3 days where she doesn't sleep, and she's cleaning the baseboards, and she's cleaning the ceiling fans, and so on and so forth, and then she'll just crash and she'll be depressed again and she'll be tearful all the time, and they go back and forth. That's where you got to be more worried about bipolar disorder, which is a great segue into the next topic, which is postpartum psychosis. Postpartum psychosis is far more significant, far more serious than postpartum depression. Certainly we see them both, we treat them both, but we see postpartum psychosis a lot less frequently, and it's a lot more dangerous. In addition, it's usually not something that we can take care of in a 6-month or 9-month or 12-month interval. It's usually something that they'll have lifelong issues with. So most often it's associated with either a history of bipolar disorder or a future of bipolar disorder. What I mean by that is they'll either come to us at 6 weeks pregnant having been told they have bipolar disorder, they're at very high risk to get postpartum psychosis. They were controlled, and then they go through all these hormonal changes and a lack of sleep and everything they've got going on, and then suddenly the psychosis will come out. The flip side of that is that Angie here could be in perfect, great shape. She has everything's good. She has her baby, and then we start noticing, okay, now her mom's telling us she's hallucinating sometimes. Her mom's telling us this. Her mom's telling us that. And these women will go on about 30-40% of the time to have a lifelong diagnosis of bipolar disorder. So it sometimes can bring out that diagnosis. Unlike postpartum depression, it's usually a rapid onset. This is the one that you guys, the nurses, will see a lot more frequently because it happens 2 to 3 days usually after the baby is born. This is a much more rapid onset. You don't have that 2-week interval. It's usually less than 2 weeks, almost always within a few days actually that you start seeing symptoms. You have a rapid onset of hallucinations, delusions, and disorganized thinking as the 3 big just things that we see. So prevalence on this one is about 1 in 1,000 births. Again, like we talked about, the biggest risk factor is bipolar disorder. Postpartum psychosis and bipolar disorder, they are kind of like two diseases on the same spectrum. One can become the other. Risk factors: history of bipolar disorder, family history of bipolar disorder, or family history of postpartum psychosis. There's actually a greater genetic component to psychosis than there is to depression. So if someone says, hey, my mom had postpartum psychosis, they admitted her for 2 weeks after she delivered, that woman is at high risk. The biggest risk factor outside of being bipolar or having a family history is someone who DCs their meds when they get pregnant. Someone who's got bipolar disorder, borderline personality, major depression, or anxiety, and they say, gosh, I read that study, or I saw that lawyer commercial on TV and I stopped all of my meds because I don't want my baby to be born with this or that. Those are people who are really high risk for postpartum psychosis. Hormones, again, sleep deprivation. The other one. The other big thing to note is stressful events, like we talked about with postpartum depression, do not affect psychosis. So these people have no knowledge of the fact that they're poor, or that their husband is abusing them, or that their financial situation is horrible, or that they have 7 children. Let me restate that. They have knowledge of those things, but those things do not make them higher risk for having psychosis. Unlike depression, where if you put someone in that pressure cooker situation and you give them the poor socioeconomic status, and they can't pay their light bill, and their husband is gone, and they're a single mother with 7 children, that will bring out postpartum depression. Postpartum psychosis doesn't usually work that way. It's more of an internal thing that is occurring. Manifestations, again, like I said, usually within the first 2 weeks, almost always within the first 2 weeks, usually within the first few days. And severe insomnia is usually the first thing we see, and that's usually a manic episode that they can't describe mania, but they'll tell you, I haven't slept in 3 days, and I just don't know, I feel fine, I don't need any sleep, and I seem to be doing great, and gosh, my house is really clean, and blah, 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 and they're talking 95 miles an hour. That's usually the first thing that we see. So compare and contrast that when you're looking at your differential diagnosis. Obviously, schizophrenia, undiagnosed, those people also have hallucinations and delusions. The biggest thing between the two is most of the hallucinations and delusions will be geared towards the child. About 65% of the time, when someone has postpartum psychosis, they'll say something delusional about the child. I'm hearing voices that tell me to harm the child, or my baby was walking, and how's that possible? He's only 4 weeks old, or whatever the case may be. It's generally about the child. Versus schizophrenic, these are the most far-fetched thing you can imagine. Like I said, I was previously the president. I'm in the CIA. There's a chip implanted in my tooth, and they're tracking my whereabouts. It's generally not about the child. Suicide rate and infanticide rates are both about twice as high in psychosis as they are in depression. So it actually is about a 4% chance that they will kill their child if given the opportunity if you're in postpartum psychosis. Postpartum depression versus psychosis. Postpartum depression is usually a history of depression either during the pregnancy or prior to pregnancy, versus psychosis, which is usually a history of bipolar or other hallucinations in the past. Postpartum depression, they'll present very tired, lack of interest in things. They just ho-hum, don't really care about anything. Postpartum psychosis, they're the opposite. They haven't slept in 3 days. They're all over the place. They're doing a million things. They've researched 17 different diapers. They've tried 14 on. They know everything there is to know about every subject. Postpartum depression is worse with the stressors and the hardship. Psychosis has really no bearing. It's not going to worsen their symptoms. It's not going to change who they are. Postpartum depression generally occurs after 2 weeks, and postpartum psychosis is less than 2 weeks. Remember also, postpartum blues, less than 2 weeks, but obviously those are very hard to confuse. They're complete different. Again, what does the future hold? About 30 to 40% of these people will have major depressive disorder. In psychosis, a good number of these will have bipolar disorder. So history of bipolar, or they'll become bipolar, history of depression will become major depression. Postpartum depression, lack of interest in the child. Postpartum psychosis, they're very hypervigilant about their child. Both of the cases that I've seen in the last few years, both of the moms said no one could take care of the child as well as they could. They both had obsessive compulsive thoughts about the child. They wouldn't let their husbands take care of the baby because there's no way he could do it the way they could do it, and he wasn't washing his hands right, and he wasn't putting the diaper on right, and he wasn't doing this right. So they're very hyper vigilant. They're very, very, very motivated versus the postpartum depression where it's the opposite. They just say, well, oh, where's the baby today? He's with my husband. I had to go do a few errands today after the visit. Just kind of the opposite effect. So this is kind of a good overview of both. You guys are more likely to see this on labor and delivery. This is a lot more likely to happen. I guess that's about a wrap.